Good afternoon, everyone, and welcome to the 2018 Harmony webinar series. My name is Gina Thorne, Chief Marketing Officer for Harmony Foundation, and it's my pleasure today to be hosting today's workshop on walking the tightrope of chronic pain and addiction. Our featured speaker today is Stephen Grinstead. He's the co-founder and Chief Clinical Officer for A Healing Place, The Estates. For those of you that are new to Harmony Foundation, Harmony is nestled on a 43-acre campus in the Rocky Mountains just outside of Estes Park, Colorado. Our Colorado residential rehab offers comprehensive treatment for adults and their family members. So who is Harmony Foundation? Our why factor is that we believe that long-term recovery from alcohol and other drugs is possible. And we do that because we believe that we're a place between two worlds. Our location in the Rockies provides a safe and quiet respite from the pain of addiction. With 50 years of experience in treating addiction, we have fostered a generation of long-term recovery who supports our clients and families for a lifetime. Harmony's staff at all levels of the organization works together to create a community of recovery support that is long-lasting. We are a 70-plus bed residential treatment program offering a full continuum of care, beginning at detox through transitional living. Located at the base of Rocky Mountain National Park in Estes Park, we offer an evidence-based 12-step program that is gender responsive. If you're interested in learning more about Harmony, we invite you to visit us at harmonyfoundationinc.com, or you can contact our admissions staff at 866-686-7867. Before we get started with our presentation today, I'd like to just let you know that we are going to be asking you to complete an online evaluation form at the end of the webinar. You typically receive those webinar evaluations within an hour after the program is concluded. If you don't see it pop into your email, please reach out to us. You can contact me at gthorne@harmonyfoundationinc.com, or you can reach out to Christy Weeks at cweeks@harmonyfoundationinc.com. We'd like to give a special thank you to A Healing Place, The Estates in California. They're an amazing program that has a very unique specialty in working with chronic pain. We know that chronic pain is a prolific issue that is emerging more and more in the addiction treatment space, and having a program like A Healing Place has been a game changer for our program at Harmony in referring clients who are really suffering from the issues of chronic pain, and how do we manage the chronic pain in addressing addiction issues as well. If you're interested in learning more about A Healing Place, The Estates, please reach out to them at ahealingplacetheestates.com. At this time, I'm going to go ahead and introduce Stephen Grinstead. Stephen, again, is the co-founder and chief clinical officer for A Healing Place. He is the author of a book, Freedom from Suffering, A Journey of Hope, as well as author of several other pain management books, including Managing Pain and Coexisting Disorders and the Addiction-Free Pain Management Recovery Guide. Dr. Grinstead is also an internationally recognized expert in preventing relapse related to addiction and chronic pain disorders, and is the developer of the Addiction-Free Pain Management System. He has been working with chronic pain management, substance use disorders, eating addiction, and coexisting mental and personality disorders since 1984. Dr. Grinstead has a bachelor's degree in behavioral science, a master's degree in counseling psychology, and a doctorate in addictive disorders. He is a licensed marriage and family therapist, a past California certified alcohol and drug counselor, and a current advanced relapse prevention specialist. And this is just the tip of the iceberg in relation to his bio. So I am going to, at this point, turn the presentation over to Dr. Grinstead. And if anybody is interested in asking questions through his presentation, please be sure to fill the questions out in the chat box on the right. We will be managing those questions towards the end of his workshop. But at this time, I'll go ahead and turn it over to Dr. Grinstead.
Good morning, everybody. And Gina, I can't get do you see the one control panel on the screen? Is it going to be in the way?
No, you're fine.
Okay, good. So anyway, first of all, I need to make sure my computer's working. And it is. So first of all, I want to wish you aloha. In Hawaiian, that's love, peace, and compassion to you. And of course, mahalo, thank you and gratitude for joining me today, talking about one of my most favorite presentations. As we're talking today, That's my view as I'm presenting to you today. Our CEO, John Stenzel, graciously offered Ellen and I this space for our 30th wedding anniversary because our place, you can't get to that side of the island right now because of the storms earlier this year. So this is really a hardship, to be doing this webinar with watching this ocean in the background and everything, but I'm into it. This is me yesterday. I wanted to go cliff diving. Ellen said no. She thought that looked a little bit too scary. So I lost. So, Gina told you just a little bit about me. And of course, that is the tip of the iceberg because I have a personal stake in this work too, because I've been in recovery for chronic pain since 1982, but I've been in recovery from alcohol and pain pills since January 1981. So I come at this from two different perspectives. And I've been working on developing the addiction-free pain management treatment system since the early mid-1990s with the help of my mentor, Terry Gorski. And it's been a real labor of love. At first, early days, it was really frustrating because in 1996, when I really developed the model, I was out on the speaker circuit warning people about this prolific use of opioids for chronic pain. It was hurting more than it was helping, and people weren't listening. So today, here we fast forward 22 years later, we're now at an intersection of chronic pain and opiate epidemics or healthcare crisis, and it's a knee-jerk reaction to a lot of the key players. The law enforcement is coming at it from one way, the Food and Drug Administration from another, DEA from another, and what we really need is to understand this synergistic problem so we can develop a synergistic solution. And that's what I've spent my whole career working on, and the past 2 years building the model at a healing place and implementing it the way I'd always envisioned it. For a lot of people, I don't know how many of you are living with chronic pain, but for most people living with chronic pain, it can become an overwhelming problem. They can get hopeless and helpless. In my early days, right with my initial injury, I was so hopeless, I almost chose suicide as an option because I thought my life was over. I had a mistaken belief because I could no longer teach karate, because I could no longer earn a living, that my life was over. But believe me, it was just the beginning. So, chronic pain costs the insurance industry a lot of money. In 2011, it was over $500 billion. Today, it's about $750 billion in pain management and lost productivity. And still, that's more money that's spent on heart disease, diabetes, and cancer combined. And what happens for people living with chronic pain is they develop what we call the pain brain. The brain functioning changes. And long-term pain definitely leads to many, many problems with people: anxiety, depression, post-traumatic stress disorder. There's a lot of different conditions people experience from living with high levels of chronic pain. Another problem is a lot of times when people are first injured or first get sick, whatever the condition is, they don't have a lot of the coexisting mental health problems, what they call the comorbidities. But over time, those develop. And when they develop, a lot of the insurance providers or the payers said, oh, that's not part of the injury, we're not going to cover it. Workers' comp is infamous for that. So, they want to compartmentalize. If you broke your leg and knee, that's the only part that gets worked on. Doesn't matter that if it impacted you psychologically, socially, and spiritually, we only work on the biomedical knee. Now, in the 1990s, there was a team of doctors that went around the country promoting opioids as a safe and effective way to manage chronic pain. And there is no ceiling dose. You just titrate the opioids up until you get the relief you want. And that led to the problem we're at today. There's about a third probably of Americans have some form of acute or chronic pain. And they said in 2014, U.S. retail pharmacies dispense 245 million prescriptions for opioid pain relievers. You know, at one point, the United States has 5% of the world's population, and we're using 85% of the world's hydrocodone or Vicodin. And, you know, it's real easy to divert these. These get diverted at the manufacturer, at the pharmaceutical level, and at the doctor's or healthcare level, and then at the patient level. And a lot of physicians now are panicking, and when someone has chronic pain and they've been treating them for a while, they get afraid and they says, I can't prescribe for you anymore. The FDA or the DEA is going to come after me. And the information on this pain comes from the New England Journal of Medicine. It was an interesting article, and if you get a chance, please check out the whole article. And by the way, if you want copies of these slides at the end, contact Gina and she will absolutely get you a PDF copy of these slides. You know, there's a lot, we're hearing a lot about people are dying. About 73 people a day are dying now from opioid overdoses. So heroin is 19% of them, and there's been a big increase in the prescription opioid. And, you know, there's been a lot of increase in the addiction and treatment of opioids too. What I've discovered and what we've seen at A Healing Place is the biomedical approach alone isn't working for this subset of chronic pain patients. And what I'm talking about is patients who have both chronic pain and coexisting psychological or lifestyle problems. And this group ends up way overutilizing the healthcare system, and they have very poor outcomes. And it keeps getting bad. You know, I just ran across this just a few weeks ago, the annual report from the CDC. In 2016, almost 38,000 people died from unintentional drug overdoses involving opioids. And over 14,000 of those was from prescription opioids. So you can see that it is a major problem. And a lot of these people are not intentionally trying to commit suicide by any means. They're just trying to stop this debilitating pain. And what complicates this for some people is they're mixing their opioids with other medications, including some of the benzodiazepines like Ativan, Valium, Xanax. There's still a lot of people that says there's no opioid epidemic. People are overblowing this, you know. Pain patients need to keep their pain meds coming. But you know something? A lot of people, almost 2 million people, suffered from substance use disorders relating to prescription opioids. And the admission for these conditions quadrupled in a 10-year period. And a lot of overdose deaths, as we mentioned. The big thing is there's a big need for medication-assisted treatment for a lot of addictions, but especially for somebody with chronic pain that's addicted to their prescription opioids. Unfortunately, many of these people do not get it. A lot of treatment programs will not offer MAT. They think it's substituting one drug for another. And for some people, though, it can mean the difference literally between life and death. We have a small percentage of our people that maybe 5–10% at the most that will need MAT for 6 months to a year before they can finally get all the other modalities in place and get themselves to a place where they can be tapered off. But here's the rest of the story. It's not just about the overdose deaths. This slide is really intriguing to me because for every death due to overdose, 10 more people are admitted for treatment for abuse or addiction. There's 32 emergency department visits for misuse or abuse of the medication. And there's a lot of people who abuse or are dependent on using non-medically. That's 825. That's for every one person that dies, there's 1,000 people that have other problems related to those opioids. What we found at a healing place over the last couple of years are some of the most common coexisting disorders that I'd like to share with you. Of course, the first one is these chronic pain patients who have either misuse, abuse, tolerance, dependence, or true addiction to their medication. 100% of our patients that we've seen in our acute setting have had major unresolved PTSD. So we need to treat the trauma or we can't treat the pain. Depression is one of the most common co-occurring disorders that goes along with having chronic pain. The anxiety disorders, including social anxiety disorders, all types of sleep problems, sleep disorders, many of these people also become dependent and addicted to prescription sleeping meds like Ambien or Lunesta. And we also have experienced some personality disorders, but many people with addiction get misdiagnosed with the personality disorders, so we're real careful about that one. Now, the next one you'll see, cognitive impairment. This is not due to the medications. This is due to living with high levels of pain 24/7, day in, day out. And many of these pain patients have had disordered eating or actual eating disorders. So if we don't treat the whole person, we don't get good outcomes. So our initial 3 to 3.5 day assessment, multidisciplinary integrated assessment process helps us see what the person's living with biologically, psychologically, socially, and spiritually. And our team has done a great job, because if you don't identify the problem, how do you identify the treatment plan for the solution? Unfortunately, there's a lot of things that get in the way for getting people their lives back and having them have a positive treatment outcome. The major thing, and I believe the number one, is our failure to either recognize or treat the coexisting disorders. Traditionally, and I'll mention this in a little bit, we've had a sequential model. We did the addiction in one place, the mental health in another place, the pain in yet another place. And we did this sequentially without communication between the disciplines. That can definitely lead to problems. Then the family system. We believe that a family needs to have as much treatment and education as the patient, the pain patient. There's a lot more severe codependency or enabling behaviors with this population. I've worked in both fields, straight addiction and pain and addiction, for many years. And I think the codependency for people with chronic pain, their loved ones, is much more intense and sometimes more sophisticated and sneaky. And a lot of times, like with addiction, these providers get burnt out, get resentful, get angry. I've seen marriages end, families disrupted. And sometimes it's not from the addictive disorder, but it's from the living with chronic pain and not having it managed effectively. Then we, the judgmental healthcare providers. I cannot tell you how many patients since 1984 that I've seen that the first thing they say is they're not taking me seriously. They don't think my pain can be as bad as it is because the MRIs, the CAT scans, or the x-rays say so. And when I ask people, why do you think they sent you here? They said, because it's all in my head and I need to come to a head doctor. He says, well, darn, that's not who I am. And then there's the blame the victim mentality for some of these patients, especially the ones that, got into, say, a motor vehicle accident because they were impaired. A lot of these pain patients, when they go into treatment and traditional addiction treatment, and I remember this in the early days, the first hospital I worked with was in 1986. I was fairly new in the field at that point, but I was living with chronic pain. I was in my own recovery, and I was doing it in a recovery-friendly manner. So Dr. Jerry Calloway and Dr. Philip Mack, the co-medical directors, hired me to be the chief therapist for the pain program. And what I saw with the staff, the clinical and the nursing staff, was they kept shaming and blaming the pain patients of being drug seeking. They're just drug seeking. But what they're really seeking is relief. So these are some of the major obstacles. But the other side, the other obstacles, are the patient's own self-defeating reactions. And number one in primary is for the patients who are passive recipients of treatment. They just come in and they want the quick fix. They want the magical bullet. They want the right pill, the right procedure, the right surgery, the right acupuncturist, the right chiropractor, whatever it is. And they're not willing to actively participate in their healing process. So they can go to the best of the best, but if they're not proactive, they're not going to get much better. A lot of these patients move into what I call malicious compliance with their pain docs just to keep the meds coming. They say whatever the doctor wants to hear, but then they go about and do whatever they do. Unfortunately, after time, many of these people get into this chronic pain trance, a hopeless, helpless state of mind to where they see no way out. It's down in the bottom of a deep, dark pit for many of these people. A tremendous amount of grief and loss and feeling ashamed and guilty. I've had some of this pop up on this anniversary trip with my wife. She wanted to go tubing, river rafting, and I knew because of the condition of my back injury that that could end up getting me paralyzed again. And once paralyzed is enough for me. But, you know, and not being able to hike as far as I used to, not being able to dive off that cliff that 30 some years ago I would have. And it's just sometimes really sad for me. And I can identify with a lot of these patients. And then the shame and guilt about not being a good parent, not being a good spouse, not being a good worker is really tremendous. And there's a big grieving process people need to work through. And like I mentioned earlier, depression is one of the most common coexisting disorders, and there's others, you know, the anxiety, the PTSD, etc. But if we don't concurrently treat those, it sabotages everything. It sabotages the pain management, and it can sabotage an addictive disorder. A lot of these patients have a lot of resistance and denial. And I'm not talking about the resistance and denial about being an addict here. I'm talking about the resistance and denial about becoming an active participant in their own healing pain management process. They've bought into the biomedical model, and they keep wanting to focus on that only, symptom management. And we go for healing. That's why we named our place a healing place. We want to heal. A lot of times, one of the biggest struggles with this population is treatment providers end up getting in power struggles with them. I can remember back to the early days, I got sucked into some of those. And then when, like in the hospital I was working with back in the late 80s, when I'd go on vacation or when I went on my honeymoon in 1988, when I came back, they were so grateful I was back because those pain patients drove them crazy. And a lot of it was they weren't meeting them where they're at. They were thinking they were drug seeking, med seeking, etc. They got into a lot of power struggles. And when we get into power struggles with our patients, nobody wins. It's a no-win scenario. The other big obstacle is the unrealistic expectations of all the different disciplines. We've got addiction providers, mental health providers, pain providers, and family members, and they all have expectations out on the extremes that can sabotage outcomes. For many addiction counselors, total abstinence is the solution. We don't want to do MAT. That's just substituting one drug for another. That's on the extremes. Then we have the mental health providers. No, we just do psychotherapy. We go to the family of origin. We just look at those core issues and we resolve why they got here. And my contention is why isn't important. It's where are they right here, right now, and where do they want to be? That's what I want to focus on. At some point, we do need to look back at the past, but not when we're in initial treatment. We need to be in the moment, in the here and now, meeting the person where they're at. And then we have the better living through chemistry approach or the biomedical approach. I call this symptom management being the solution. And then for the poor family members, they just come and say, please just fix them. I can't deal with this anymore. A lot of the patients that we have had, it's been a hard sell to get the family members integrated into the family program because they think it's their loved one's issue. They just need to go deal with it and everything will be fine. But if the family system doesn't heal, that's a big relapse trigger and a trigger for maybe a divorce or separation or blowing up the family. So moving out of the problem and into the solution, I believe what we really need is to have integrated, concurrent, targeted, and collaborative treatment delivered in a very strategic manner. And as you'll see on the lower right-hand corner, the patient needs to be at the bullseye. All the focus needs to be meeting the patient where they're at. I believe that's what needs to happen. Back in 1995, when I first started conceptualizing addiction-free pain management, I was talking with Terry Gorski, and he says, well, your first step is to go look at the literature and see what happens for people with chronic pain and coexisting addiction when they go in to get help. And at the time, I was teaching at several major Bay Area universities, UC Santa Cruz, UC Berkeley, Santa Clara University, and Stanford Medical School. So I had access to all those libraries. And for some of you newbies that are come along since Google, we didn't have Google back in the 90s. It was a whole different internet search system back then. That's why you had to make good friends with the librarians so they could hook you up with the best data. But after about 4 or 5 weeks, I got very frustrated because I couldn't find anything published hitting that parameter of people with chronic pain and coexisting addiction seeking help. And I felt a little frustrated, hopeless, helpless, so to speak. And what in the heck am I going to do? And so I went back to Gorski, whining and complaining. And he said, Steve, it's obvious. I says, what's obvious? He says, you need to go out and do your own research. So I did. I started going out in Northern California with pain providers, addiction treatment providers, both medical model and social model. Anywhere I could find a pain patient, chiropractors' offices, pain clinics, everything. I'd go in and was doing assessment interviews with all these patients. And I started seeing some things that I ended up, at first it was the addiction pain syndrome, but as the model sophisticated, it became the coexisting chronic pain syndrome. And this is where we need to identify the synergistic problems so we can develop a synergistic treatment plan. So people living with chronic pain, their life's impaired biologically, psychologically, socially, and spiritually. They have a lot of deficits. They have a lot of problems. For people living with a mental health disorder, they're also being impacted in those 4 quadrants, biopsychosocial, spiritual. And some of them are similar and some of them are different than the pain people. For people with an addictive disorder, they have a different set of struggles or consequences biologically, psychologically, socially, and spiritually. So traditionally what has happened is when you have this patient, they might go into, at the top, a chronic pain clinic, and they'd get the pain condition dealt with. But that left 2/3 of the problem that wasn't being addressed. Other people might go to a mental health professional or a mental health hospital. Again, a different third of the problem was being addressed. And then some people went into an addiction treatment program because the addiction was destroying their lives and their families. And they were dealing with yet a different third. Now, back in the 90s, there started to be dual diagnosis programs that were certified to work with addiction and mental health. And now we're dealing with 2/3 of the problem, kinda. But that left the chronic pain. So what we need is a synergistic treatment system to deal with this coexisting chronic pain syndrome, because 1 + 1 + 1 don't equal 3. It's 4 or greater. and there's a synergistic effect, and we need to have a synergistic solution. And that's why I've spent most of my career developing a system to help people with chronic pain and coexisting disorders. There's a saying that goes back a long time, that knowledge is power. And we believe that. I really think education is one of the most important components of the treatment process for our pain patients. These people to become active participants in their own healing process. The problem is, and I think that's true for all of us, is we have an idea of what the solution is, what we need. As providers, we know what these people need, sometimes even before they tell us their story, before we get the initial data. So we always start with our patients in one of the early sessions when they first get to us, is we talk about the empty cup syndrome or beginner's mind. And this goes back to a story, back to the 1800s. There's this American college professor that wanted to learn everything about Zen. He'd been hearing about it, and so he started a worldwide tour searching for Zen. And he just kept getting all this information, but he kept hearing everybody saying, you really need to go see Nanin. He's one of the top Zen masters on the planet. This was back in the 1800s. And so he finally did. He finally went to see this guru, and he knocked on the door, and then he proceeded to start telling Nanin everything he'd learned about Zen. And so Nanin laughed and smiled. And he says, come in, professor, come in, let me serve you tea. And as he was sitting there serving the professor tea, professor was holding out his cup and saucer, and Nanin was pouring the tea into the cup. And pretty soon it went over the edge. The professor starting to get a little anxious. Then it went into the saucer, and it went over and burned his hand. He says, what are you doing? And here's what Nanin said to him. He said, like this cup, you are so full of your own opinions and speculations. How can I show you Zen unless you first empty your cup? I had a similar experience when I was training in the martial arts with Sensei Kim. I was brand new black belt, and now I joined the other black belts in the dojo. And Sensei Kim called us together for a special session, just the black belts. And for an hour and a half, all he had us do was basic blocks, kicks, and punches. And we were kind of rebellious about this. Wait a minute, we're black belt level. Why are you doing this? And then he told us, it's really important to stay in beginner's mind. In the expert mind, you're limited to outcome options. The beginner's mind is infinite. So we want to help keep our patients in their beginner's mind. Part of the education we do is really spending a lot of time educating people about the different types of pain and helping them understand. One of the first things I do is try to educate them that they need to see pain as an ally rather than an adversary. This is not an easy sell. So we talk about pain has a reason. It's a warning sign built into us. We have pain receptors all throughout the body and inside the body to warn us that something's wrong and needs attention. With acute pain, it's usually easy to recognize, easy to treat, and has a limited healing process. Now, chronic pain is a whole different animal. Some people with chronic pain, all of the biological healing that can be done happens within the first 6 months to 9 months. And what starts happening then is the pain brain, the neural system starts getting remodeled. The other big problem for people with chronic pain, and one of the reasons they end up overusing medication, is when they have pain flare-ups. So we want to do a whole thing about non-pharmacological pain flare-up planning. Anticipatory pain. This is one of the biggies. Years ago, I wrote an article titled Coping with Anticipatory Pain. And then a few years later, I updated that to Moving Beyond Anticipatory Pain. Now, the other type of pain that really is problematic for a lot of people is the nerve pain or the neuropathic pain. And a lot of times people are overprescribed opioids to numb out those feelings when a lot of times other modalities are much better, like acupuncture, for example, sometimes even chiropractic. But if it's a medical approach, we want to use things like gabapentin, pregabalin, duloxetine or Cymbalta, some of the different medications that are FDA approved for neuropathic pain management. But the biggest point, and I'm going to expand on this a little bit, is teaching our patients how to make peace with their pain. Because it's extremely important that they get this. If they get nothing else in treatment, if they get this, they will have gotten a lot. They need to learn to stop fighting their pain. Call a ceasefire, because when they're fighting their pain, they're fighting themselves. And they're into what we call suffering, because there is a big difference between pain and suffering. That's the other thing we assess early on with our patients, is how much of your pain was physiological and how much of it is psychological, emotional. And not surprisingly, people usually score higher in the psychological, emotional, and that's very exciting because our biopsychosocial spiritual treatment program really does wonders for that. So when living with chronic pain, I know for me, I had to stop seeing pain as public enemy number one, as my adversary. I need to really start learning and listening to my pain and seeing my pain as my best friend. Today, when I have a pain flare-up, it's like a barometer for me. It's telling me either I did something too much, like the other day I was snorkeling in a place that had really strong currents and I really had some low back pain afterwards, or sometimes it's getting into a stressful interaction with colleagues or with my wife, Ellen. And that will also lead to pain flare-ups for me, including migraine. The big thing I tell people is pain's inevitable, but suffering is optional. You can learn to stop suffering. And making peace with your pain is crucial in order to have that freedom from your suffering. And not only is it preferable, but it is possible. We want to educate people that we do need to look at the biological part of their pain, because that's the ascending pain signal. That's the signal that goes from the point of injury or impact up to the thalamus that says, warning, warning, something's wrong. Now, what happens next is it gets interpreted, so it gets assigned a meaning. And sometimes over time, that signal gets distorted or amplified, and it becomes suffering. But there's also the social cultural. This is part of the descending modulation effect of living with pain. A lot of times people are taking on the role of I'm a failure, I'm a loser, I'm not good enough. And then there's their history, prehistory, family history, and cultural beliefs about pain. In my family system, I had one parent on one end of the spectrum and my other parent on the other end. My dad was on the side of you don't show pain, you don't admit pain, and if you cry, I'll give you something to cry about. You need to be tough and be a man. On the other end of the spectrum was mom. One thing I didn't mention, I was born in 1950 and I'm the oldest of 9 boys. Mom had 9 boys in 14 years and no twins. So growing up, you might imagine that my mom was pregnant during most of my early childhood. And it was really hard to get extra attention. But when I got hurt or sick, mom was there with nurturing, comfort. And we used to call her Medication Cabinet Marge. So she would always go for the biomedical. And I learned that from her. Then we have the fourth component that often doesn't get identified or talked about, and it's the impact of chronic pain on people's spiritual values, practices, and principles. So we do full in-depth assessments in all four of these areas for functioning. How well are you functioning biologically, psychologically, socially, and spiritually? We do pre-post measures on all of these. And at 3 weeks, we do the second pre to see where we're at with the treatment plan and tweak the treatment plan. What we've seen is one of the areas that has grown the most is the spiritual. And this is our logo, again, that I'm going to go over now. But it's really crucial that we work with the whole person. Yes, we look at their chronic pain. Yes, we look at substance use problems. Yes, we look at other psychological problems. Let's take a look at medical conditions, and let's take a look at your unsuccessful track record of medical interventions, biomedical interventions. What's going on psychosocially, friends, family, community, work, employment, vocation, and spiritual. How have you been impacted in that level? And of course, the big thing, your levels of functioning and quality of life. So we want to address this, identify the problems so we can develop an effective treatment plan. So in the biological area, we have a history and physical, a nursing history and physical. We have all the pre-existing documentations we can get for people, and we see where the person's at biologically. How's their diet? How's their nutrition? How's their exercise? What are they doing for stress management? Then on the psychological, and I'm going to cover a lot of the interventions we teach the patients in a few minutes, but we do the same assessment here. You know, we want to see where they're at with anxiety, stress, depression, trauma, all the different psychological problems that people may have. How has their social life been impacted? Friends, family, community. So we do a family assessment device as one of our pre-post measures. So we want to see how living with chronic pain and coexisting disorders has impacted their social life. And then, of course, to tie it all together, we do 2 different spiritual evaluation assessments too. And then we design the treatment plan to address the whole person. And we always go back to this logo with the patients to remind them that the spiritual is the glue that holds it all together, and you need to be working in each 4 of the quadrants. So best practice treatment components include biomedical interventions. Absolutely. I'm not saying do away with them, but let's not be the only thing we do. What do we need to do psychologically, clinically? What are some important non-pharmacological or holistic approaches that we can develop? How can we teach people to develop a healthier support system, especially when we start developing their continuing care and relapse prevention plans starting in week 1? And then implementing the spirituality focus and help them build a new spiritual plan. So we want to have, for chronic pain and mental health disorders, for medication management, recovery friendly is the key here. And it needs to be evidence-based, recovery friendly. That means it's not going to trigger an addiction relapse. Minimum effective low dose, individualized and strategic. So it's not like everybody gets this or that prescription when they come in. Oh no, everybody is assessed to see what is the minimal amount and the lowest dose and the fewest medications they need. Some of these people come in with grocery bags full of pill bottles, and they have been taking as many as 25, 30 different prescriptions every single day. So that's the other thing we monitor is meds they were when they came in versus what were they on when they went out. What a big difference. We do compliance monitoring by doing random in-depth urine drug screening. Not as a COP method, but more of a therapeutic method, and teaching them that this can be a part of your relapse prevention plan is setting up with someone after you leave us to have random testing. And that helps you if you get tempted, you'll remember, oh, I might be tested. That might give you that little extra edge from not giving in. For a lot of our patients, we want to make sure it's also cost effective. So we search, while they're with us, we search for the lowest cost pharmacy in our area. And for some medications, it's pharmacy X, for others, it's pharmacy Y. So we want to help them get the best bang for their buck. Even if they get most of it's paid by insurance, we don't want to overutilize people's insurance either. So talking about some of the non-pharmacological holistic practices, our major goal here is to help them step away from the pure biomedical model. We want to, the emphasis again, and I know I'm being repetitive, but it's purposeful repetition, is we want to make sure that we're addressing the whole person, biopsychosocial and spiritually. We use a body, mind, spirit approach. We even have a spiritual advisor come in every week to work with our patients, and they love her. Some of the biological interventions that we do are diet, nutrition, and exercise. With the exercise, we help them set up an activity pacing plan. Some of the people need an extra push, kick in the butt, so to speak, but a lot of us, I know this was true for me, I needed to slow down. Teaching people how to do sleep hygiene and how to rest. A lot of these people, that was their major fear, was we're going to take them off Ambien or Lunesta. How are they ever going to sleep? So we teach them some non-pharmacological and some healthy recovery-friendly sleep aids. Activity pacing has one end of the spectrum of, slowing down. On the other end, it's the non-avoidance, speeding up. Good hygiene, recovery-friendly medication management plan. We use things like hydrotherapy, massage therapy, yoga, aqua exercise, acupuncture, chiropractic. Good stress management, teaching people how to breathe and how to use guided imagery. I believe it's really crucial, especially for people recovering from a substance use disorder, to eliminate or reduce nicotine, caffeine, and sugar, because all of those exacerbate or turn on post-acute withdrawal. We offer both neurofeedback and biofeedback. That combination is excellent for the people with their trauma, helps with trauma resolution. It's also good for anxiety. It's also good for sleep. Psychological, the biggest and most important part, I believe, is education. Everything there is to know about pain, recovery, addiction, and relapse. Teaching people how to not only manage their emotions, but how to articulate and identify their emotions. We like to intersperse some right brain, music, art, journaling, collage. One of my favorite pain flare-up modalities I use is avoidance by distraction. Instead of focusing on, ouch, this is really bad, I'm focusing on what I'm doing, like looking at this beautiful ocean or going for a walk by the beach. Cognitive behavioral restructuring is at the core of our model. We teach the patients this early on. We need to start with identifying your mistaken beliefs and perceptions that lead to the self-defeating, addictive, or negative thinking patterns that lead to uncomfortable emotions. The combination of thoughts and emotions lead to urges or impulses to do something that's not so healthy, make bad choices and do the wrong thing. And when you do the wrong thing, it has social consequences. So we have to go through and teach them on all these areas. We need to look at it. One of the big things we work a lot on is helping them identify and manage denial, their defense mechanisms, and their cognitive distortions. Teach them how to challenge negative self-defeating thinking. We teach them how to meditate. We use hypnosis, self-hypnosis, a lot of psychotherapy and counseling, teaching people, most importantly, how to obtain balance in their lives. Socially, like with any people in addiction recovery, you've got to let go of the people that are a problem. And maybe sometimes it's not let go, but it's to educate. We have in-house Chronic Pain Anonymous support meetings every week. For some of our patients that identify as alcoholics or addicts, we want to hook them up with Pills Addicts Anonymous, preferably. If they've already been going to other programs like AA or NA, we will support them with that. But for pain patients, a lot of them get told, if you're on medication-assisted treatment, you're not really in recovery. And so it's very demeaning for these people. We want to help them develop people who are safe to be on their team. Where can they go? What's safe? Physically safe, psychologically safe, relapse safe. For a lot of these people that have been in that isolation tendency and chronic pain trance, we need to help them learn that having fun with others is really an important part. A lot of people want to go from step 1 to step 9, making amends. So we talk about the importance of making amends by starting with changing your behavior. And when you work those first 8 steps, then you can start making the amends. We are 12-step informed in our program. We are not 12-step based. We help educate people about the importance of the 12 steps for social support. We want to involve the family. So we have an online family component that's self-paced, where family members can get parallel information their loved one's getting, and then they come in for a 2.5-day interactive on-site workshop that ends with equine therapy for the family and patients. One of the most important things, I think, is teaching patients how to set appropriate, asserted limits and boundaries, and for them to continue to be very proactive. Some people have no boundaries. Some people have rigid, aggressive boundaries. Communication, communication, communication. I messages versus you messages. We like to use the transactional analysis parent-adult-child communication model because it's so simple and it's so a lot of visuals that help patients and their family members see how you want to, your goal is to go for adult-to-adult conversations, not parent-to-child. And the spiritual, again, a big part of it's balance. Some people find, like me, my favorite spiritual spots are in nature. Prayer by themselves or with others. Individual or group meditation. If they're going to buy into the 12 steps, work the steps. Chronic Pain Anonymous 12 steps is phenomenal for pain patients. One of the hardest parts and one of the most neatest parts for me and for many of the patients I've worked with is learning to love self and forgive self. And I think faith in a higher power is another piece for people. A lot of people found or rediscovered their spiritual higher power while they were with us. And developing a personalized spiritual practice, I think it needs to be both by themselves and with others. And some people, it's really reconnected them to their religion, and they got reinvigorated with their religion, or they developed other spiritual activities or found other spiritual modalities. So people that don't do so well are ones that are maliciously compliant. They want to become pain-free with minimal effort. They're not motivated to experience with the traditional and non-traditional, and they lack positive family social support. So what we want to do is create high-outcome patients who become actively involved, active participants, becoming available. We want to help people let go of the magical thinking and are willing to work. We want them to be self-starters, experiment with both traditional and non-traditional concurrent modalities. And again, making sure that we bring the family in so they have positive family social support. And we use a lot of different outcome measures because we want to get the people to become knowledgeable, active participants. They're the captain of the team. It's their life, it's their recovery. I believe my job is to be a coach or a guide. Want to use collaborative, strength-based, challenging approaches, have a collaborative treatment plan with full patient input, and have a developed strategic recovery and relapse prevention plan for all four quadrants: bio, psychosocial, and spiritual. And we want to look at medications, pre and post. We measure post-acute withdrawal, biofeedback, stress anxiety assessment, my pain assessment that helps us differentiate between pain and suffering, the PCL5 PTSD checklist. We use the DAS, Depression, Anxiety, Stress Scale, the family assessment device, and biopsychosocial spiritual functioning assessments, spiritual index of well-being, quality of life, and patient's goals, and nutrition, body mass index, functional capacity if indicated, like for workers' comp patients. The pain outcome profile, if you're not familiar with this, the Academy of Integrated Pain Management, this is, if you're working with people with chronic pain, this is one of the most research-based instruments out there that has 7 different scales that we find very helpful in developing the initial treatment plan. So that's it for me. Now it's time for any comments or questions.
Thank you so much, Dr. Grinstead. That was wonderful. We do have a question from James Hart. He asked, can you speak about introducing MAT options to clients with chronic pain? For example, we see clients that are ready to stop everything, quote unquote. They are identifying as an addict and ready to make changes. Then we see them really hurting. I want to help people address this in advance so they know MAT options and how that may or may not impact their pain.
I run into that all the time, that people are in this black or white thinking. That's the addiction thinking. So the first thing I point out is, I think your addict brain's at work here. I think you need to access your recovery brain here and realize that you need a bridge. Pain patients especially need a bridge, and I introduce MAT as a bridge. It's not a ongoing maintenance. It's a transitional modality. You need to have a bridge to get you from where you're at to where you want to be. And medication-assisted treatment can be that beautiful bridge for you. And let's talk about all your fears. What are your fears about being on recovery-friendly medications? What's the best thing that'll happen if you go totally abstinent? What's the worst thing? What's the worst thing that'll happen if you do medication-assisted treatment, and what's the best? So we help them problem solve and come up with their own solution, but we present it as it's a bridge. It's not a replacement. It's not replacing one drug for another. I hope that was helpful, Mr. Hart.
Thank you so much. That's great. I don't see any other questions that have come in at this time. For folks that are interested in getting in touch with you, what's the best way that they can reach you?
Well, for the next week or so, you're not going to be able to. I'm on my anniversary trip.
Right, no, of course. So we don't want to bother you any more than we have on your anniversary trip. If they needed to get in touch with you in regards to accessing additional questions after you return, is there a good way for them to reach out to you?
Yeah, my email address, drgrinstead@ahealingplacetheestates.com.
Terrific. Great. Thank you so much. On behalf of Harmony Foundation, we want to thank all of you that had the opportunity to participate in today's webinar. Again, special thank you to A Healing Place, the Estates, and Dr. Grinstead for his time. Again, he took time from his 30th anniversary vacation to do this webinar, and it means a great deal. So many thanks for that. For those of you that are looking for continuing education credit, you should be receiving a certificate from us no later than Friday. If you don't receive that information, please reach out to me and I'll be happy to take a look at that. Sometimes these certificates get caught up in spam folders, and so we want to make sure that you get your certificate. Please stay tuned for our workshop next month. Mike Lewis, our spiritual advisor, is going to be doing a full workshop on spirituality, and that's scheduled for November the 28th. and look up for the email registration for that in the next week or so. Again, thank you again, Dr. Grinstead, and to the Healing Place, the Estates, for your time today.
Thank you, Gina, and aloha and mahalo.
Have a good one.